Good morning, everyone. Today is Monday, June 16th, 2025. I'm Dr. Smalls, Director of Professional Development for the Maryland Department of Health's Developmental Disabilities Administration. We welcome you to today's DDA-Operated Medicaid Waiver Amendments webinar. Before beginning, we want to ensure civility for all meetings. The free expression of diverse viewpoints is a fundamental value of our group. This freedom carries the responsibility to engage respectfully, which means treating one another with dignity and respect in good faith. Uncivil behavior, disruptive conduct, abusive language, threats, or harassment will not be tolerated and may lead to being excused from the meeting. On the panel today, we have Robert White, Chief Operating Officer, Rhonda Workman, Director of Federal Programs and Integrity, and Nova Evans, Deputy Director of Federal Programs and Integrity. If you would like to use closed captioning so that you can read what is being said, click this button. Sometimes the transcription is not exact, but it's pretty close. Today's presentation is available in the Handouts section for you to download. Click here where you see the paperclip to download the presentation slide deck. The webinar is also being recorded and will be made available on the DDA's YouTube channel and the DDA's website. Currently, everyone is in mute status and your mic is muted and your cameras are disabled. If you have a question, would like us to read and answer later in the presentation, click here where you see the question mark to add your question. And now I'd like to turn the mic over to Robert White. Good morning, Robert.
Good morning, Dr. Smalls, and thank you. And good morning, everyone, and thank you for joining us today as we discuss important updates regarding the Developmental Disabilities Administration's Medicaid Waiver Amendment application for 2025. My name is Robert White, and I am the Chief Operating Officer for the Developmental Disabilities Administration. First and foremost, I would like to emphasize that your participation and input are crucial to ensuring that our waiver programs effectively support individuals and families across Maryland. In today's session, we'll do a few things. First, we'll walk through significant amendments aimed at creating a single streamlined Medicaid waiver, the Community Pathways Waiver. This single waiver will simplify service delivery, enhance efficiency, and provide equitable access to all essential services, including meaningful day activities, residential supports, and other individualized supports. Next, we'll also review the fiscal year 2026 budget bill and the Budget Reconciliation and Financing Act of 2025 requirements passed by the Maryland General Assembly. This bill requires an amendment to the waiver and is part of the application. The application also includes the updates made by CMS to the Individual Family Directed Goods and Services Technical Guide. We will also highlight what we believe are positive changes based on the input we have received from you and others through our various channels of engagement, which include new community provider opportunities related to assistive technology, environmental modifications, and family caregiving training and empowerment services, among others. It is important to note that many of the changes you will hear about this morning will go into effect on October 6, 2025. And you will have until July 8, 2025 to provide your feedback and suggestions for consideration. We have heard your questions and concerns and will dedicate time after the briefing for you to provide constructive feedback and ask questions. Your perspectives and experiences are essential to shaping these services. We are committed to engaging with you and listening to your insights and ensuring that our waiver services meet the evolving needs of our community. In addition to today's briefing, we will host additional opportunities tomorrow, June 17th, for you to engage and provide feedback. These additional opportunities start with a session dedicated to the waiver application and input process from 9 to 11:30. Another session devoted to the self-direction model will also occur tomorrow from 12 to 2 p.m. We will conclude with a session dedicated to services and provider qualifications from 2:30 to 4:30 p.m. All sessions will be recorded and posted on DDA's website. Again, the formal public comment period started on Monday, June 9th, and will continue through July 8th. We want to emphasize the importance of the public comment period to give as many people as possible a chance to participate in the process. With this collaborative spirit in mind, let's begin today's discussion. Joining me today are Rhonda Workman, Director of Federal Programs, and her Deputy Director, Nova Evans. Rhonda, please kick us off.
Thank you, Robert. Good morning. Next slide, please. Thank you for joining us today as we share information related to the 2025 DDA-Operated Medicaid Waiver Program amendments. My name is Rhonda Workman. Today, we will begin by sharing a brief overview of our programs we operate on behalf of Maryland Medicaid. As Robert mentioned, we will also be sharing information regarding amendment requirements related to the legislative fiscal year 2025 budget and the Budget Reconciliation and Finance Act, and program challenges and strategies to address. We will also share our amendment vision and purpose, followed by an overview of services and appendices proposed changes. Throughout the amendment, changes were made to enhance clarity, improve access and accessibility, promote equity, and align services with current policies and regulations. Key changes include clarifying and/or updating service requirements, training and provider qualifications, virtual support provisions, and performance measures. Updates also include adding new information and processes as required by the Center for Medicare and Medicaid Services. We are also proposing removing outdated language such as providers transitioning to the LTSS Maryland system and enhancing plain language. We close by sharing information regarding the public input process, additional stakeholder engagements, and resources. We have created a dedicated DDA amendment webpage that includes track change documents of our proposals for your review and input. For more detailed information regarding current standards, please refer to the specific approved waiver, associated regulations, policies, and guidance. Before we begin, we also want to share that the DDA staff are always available to provide assistance and answer questions. Next slide, please.
Good morning, everyone. My name is Nova Evans. As stated, we will start today's presentation by providing an overview of what a Medicaid waiver is and the DDA-operated waivers as per the currently approved Center for Medicare and Medicaid Services waiver applications. Next slide, please. So what is a Medicaid waiver? A Medicaid waiver is a federal medical assistance, also known as Medicaid, program. Waiver means that some of the regular Medicaid rules are quote-unquote waived. That means they are not applied. Waivers are typically intended to give states flexibility to serve specific populations and provide services in innovative ways and to avoid institutionalization. Waiver programs are approved for a 5-year period and then must be renewed. An amendment can happen at any time if needed. The DDA currently operates 3 Medicaid waiver programs on behalf of the department. So this presentation will talk about the upcoming waiver amendment. As you see here on the slide, the 3 DDA-operated Medicaid waivers currently include the Family Supports, Community Supports, and Community Pathways waiver. Each has a different eligibility requirements and access to different services, which we'll go over in a few moments. The 3 waivers collectively offer 52 services in total through 2 different delivery systems: the community provider managed, also known as traditional model, and the self-directed services model, where the person serves as the employer of record. Next slide, please. So this slide notes meaningful day services offered through the waiver. As you can see here, there are employment services, career exploration, supported employment, community development services, day habilitation, and medical daycare. Please note, meaningful day services are currently only available in the community supports and community pathways programs. Next slide, please. This slide notes the various support services offered through the waiver. As you can see here, we offer assistive technology, behavioral support services, environmental assessment and environmental modification, family and peer mentoring supports, family caregiver training and advocacy supports, individual and family-directed goods and services, housing support services, live-in caregiver services, nursing support services, participation, education, training, and advocacy supports, personal support services, remote support services, respite care, support broker services, transition services, transportation services, and vehicle modifications. Most of these services are currently available to participants in all 3 waivers that we operate on behalf of Medicaid. They are the Family Supports, Community Supports, and Community Pathways waiver. Next slide, please. Thank you. This slide notes the various residential services offered through the waiver, and these are currently available to participants in the Community Pathways waiver only. And they are community living group home, community living enhanced supports, shared living, and supported living. Next slide, please.
Thank you, Nova. Now let's review some information related to the budget bill and program challenges. Next slide, please. The fiscal year 2026 budget bill and the Budget Reconciliation and Finance Act of 2025 requires amendments to address cost containment strategies. This includes updating dedicated hour rates, specifically changing the rate for residential dedicated supports from 87% to 86% of the fully loaded brick, updating geographical differential rates for services. Geographical differential rates are used for Calvert, Charles, Frederick, Montgomery, and Prince George's counties. The budget bill includes creating a new day-to-day administrative support waiver services, and also the Budget Reconciliation Finance Act updates individual and family-directed goods and services by reinstating the ability to establish a limit and adjustments to our slots. Next slide, please. We would also like to address challenges that the state and stakeholders have identified. Operating 3 Medicaid waiver programs for individuals with developmental disabilities is not efficient, creates confusion among stakeholders, and requires duplicative processes, reports, and impacts staff resources. Creating one program will help to decrease overall volume of applications to the Eligibility Determination Division, or EDD, addressing stakeholder concerns with delays, unresponsiveness, etc. It will also decrease waiver application packets for coordinators of community services, decrease person-centered plans for review by the DDA regional offices, and speed up participant enrollment. Currently, individuals' needs that can no longer be met in their approved Medicaid waiver program have to disenroll from that program and complete a new waiver application process to receive services. New applications and delays in processing can impact enrollment and access to services to support health and safety needs. Creating one program will support immediate need to access services and address health and welfare needs. As discussed during the legislative session, there are several concerns related to sustainability of the DDA-operated Medicaid waiver programs. Costs for services, such as dedicated hours, self-directed service utilization, and other factors, are growing at a faster rate, impacting sustainability of the program and impacting the federal cost neutrality requirements. We will continue to work with all stakeholders, including legislators, on program sustainability strategies over the next year. As needed, additional amendment proposals can be considered. Next slide, please. Now let's review some amendment overviews. Next slide, please. This amendment vision is for a comprehensive and sustainable Medicaid waiver program. This includes action taken to inspect and review programs and recommend a better design, to update service definitions with the Budget Reconciliation and Finance Act requirements and from program sustainability, and consolidation of the DDA-operated Medicaid waiver programs so that all participants can access needed services. Today, we are going to share some information about the waiver amendments, current status, and next steps. We have and will continue to engage with stakeholders. Next slide, please. This slide is an overview of the amendment purpose. It includes to streamline and enhance service delivery by merging the waivers into a single comprehensive program, the Community Pathways Waiver. By merging the 3 waiver programs, all participants will have access to the full array of support services, meaningful day services, and residential services based on assessed need. This will improve efficiency, ensure equitable access, provide a more person-centered approach to support, and increase that timely access to services. Having one program will also reduce the duplicative processes currently impacting our staff resources, as we mentioned, related to the Eligibility Determination Division, regional offices, financial management counseling service providers, and coordinators of community services. Next slide, please. This slide shares additional information related to the amendment purpose outlined in our proposal. It includes to ensure greater transparency, streamline service delivery, ensure funding is outcome-driven and sustainable, meet federal assurances, and reinforce regulatory compliance within the Medicaid waiver program for both service delivery models. This includes reducing our risk for federal audits and recruitment from audits and or under the new federal administration. Next slide, please. Our purpose also includes to incorporate and clarify program standards and requirements. This includes in-person health, welfare, and service monitoring visits. It also includes incorporating policy standards such as the Meaningful Day Service Policy, Training Policy, and Competitive Integrative Employment requirements. We want to be transparent about the service opportunities and standards. We have updated service descriptions to better clarify terms and scope. For example, we have streamlined the support broker description and scope using information from the updated Center for Medicare and Medicaid Services Technical Guide. With the consolidations of the waiver, we can establish one set of regulations versus 3 separate regulations, which would be required for each of the programs. One set of regulations will help to reduce complexity, duplication, and confusion among stakeholders. We will also seek to create and seek input on user-friendly manuals, noted in plain language, similar to our collaborative effort around the Guide to Services. Next slide, please. This slide is a visual of the Medicaid waiver consolidation. Through an amendment, the DDA proposes to consolidate the 3 waivers into one comprehensive waiver beginning October 6, 2025. By merging the Family Supports Waiver, Community Supports Waiver, and Community Pathways Waiver into a comprehensive program, again, all participants will be able to access the full array of support services, meaningful day, and residential services based on assessed need. This will improve our efficiency, ensure an equitable access, provide more person-centered approach to supports, and increase timely access to services. Next slide, please. So we'd like to provide a little bit of an overview of what a Medicaid waiver application is. Next slide, please. This slide is an overview of the structure of a Medicaid waiver application. Each application includes specific appendices, like chapters in a book, that contain required information and/or options for state to consider. Appendix A, referred to Waiver Administration and Operation, outlines the state's responsibility for managing and overseeing the waiver programs. It details the roles of different state agencies and how they ensure compliance with federal Medicaid requirements. Appendix B, Participant Access and Eligibility, outlines the state's responsibilities for determining participant eligibility and ensuring equitable access to waiver services. Appendix C, Participant Services, outlines the state responsibilities regarding participant services and service planning. It describes the types of services available, the criteria for those services, and how they can be delivered to meet the needs of participants. Appendix D, Participant-Centered Planning and Service Delivery, outlines the state's responsibility for ensuring the waiver participants receive services based on person-centered planning process. The process ensures that individuals have a say in their care and receive services tailored to their needs, goals, and preferences. Appendix E, Participant Direction of Services, outlines the state's responsibility when waiver participants are given the option to self-direct their services. Appendix F, Participant Rights, outlines the state's responsibilities to ensure that the waiver participants' rights are protected and they are safeguarded from abuse, neglect, and exploitation. Appendix G, Participant Safeguards, outlines the state's responsibility for ensuring participant safety and service continuity during emergencies, disasters, or other disruptions. Appendix H, System Improvement, outlines how the state ensures compliance with federal requirements, monitors service delivery, and improves the quality of service for waiver participants. The state must implement a quality improvement strategy to monitor and enhance waiver services. Appendix I, Financial Accountability, outlines the financial accountability responsibilities of the state. It details how the state ensures proper financial management. It discusses rate-setting methodologies, billing, and payment procedures, and financial safeguards. Appendix J, Cost Neutrality Demonstrate, outlines how the state demonstrates that the waiver is cost neutral during each year. The state must ensure that the waiver does not cost more than institutional care over the life of the program. Throughout this presentation, we will go through appendices and share some proposed updates. Please see the track change proposed waiver amendments for additional information. Next slide, please. So the first section of the waiver is the amendment request and main proposal. Next slide, please. This section includes information and documentation related to the purpose of the amendment, including the summary and an overall overview of each appendix and service updates, and a brief description where we have added information regarding the reasons participants are disenrolled from the waiver program and regarding waiver re-enrollment. Individuals are disenrolled from the Medicaid waiver program when they no longer meet eligibility requirements, when they voluntarily choose to disenroll, for example, when they move out of state, no longer have a service need, or choose to receive supports from another program, when they do not receive at least one waiver service every 6 months, when they refuse in-person health, welfare, and service monitoring visits, when they fail to participate in or otherwise complete any assessment or screening required by the department, such as the health risk screening tool and support intensity scale, and when they refuse coordination of community services or financial management and counseling services as applicable. If an individual is terminated from enrollment in the Medicaid waiver program, the individual may re-enroll in the Medicaid waiver program if the individual meets eligibility requirements and the Medicaid waiver program has a slot or a space and funding available to support waiver re-enrollment. As individuals may be re-enrolled in the Medicaid waiver is provided in either during the same waiver year, within 90 days of termination or disenrollment, or subsequent waiver years based on reserved categories and placement on the DDA waiting list. If an individual is not eligible for re-enrollment, then the individual may be placed on the waiting list if the individual has a developmental disability. We have also included information regarding the Waiver Advisory Council, and after the public comment period ends, we will summarize input received and note it in this appendix. We have also included information under a transition plan section to share how we will implement the new updates. This includes information related to technology system updates we are making and glide paths for adding or removing standards as applicable. Technology systems include LTSS Maryland, the Medicaid Management Information System, also known as MMIS, and MD Think, which includes the Eligibility Enrollment System. I'm now going to turn it back over to Nova to share information regarding the next waiver appendix. Next slide, please. Nova, if you're speaking, we're unable to hear you.
Thank you very much. Yes, let's now review the proposed updates for Appendix B, Participant Access and Eligibility. This appendix outlines the state's responsibilities for determining participant eligibility and ensuring equitable access to waiver services. Next slide, please. The proposed updates to Appendix B include updating eligibility to include all ages. Expanding eligibility to all ages will ensure that more individuals can access the services they need and promotes person-centered services. Updating the total number of unduplicated participants, incorporating the family supports and community supports participants. adding new Medicaid eligibility groups, including pregnant women, infants and children under the age of 19, and foster care, and updating performance measures to include information gained from the Quality Improvement Organization targeted case management reviews. The Quality Improvement Organization conducts targeted case management reviews and analyzes information regarding individual and systemic deficiencies. The Quality Improvement Organization shares findings with DDA and provides recommendations on remediation and overall quality enhancement. DDA considers recommendations and has made updates to improve policies, waiver proposals, including improving performance measures based on this data. Next slide, please. We are also proposing updates to reserve categories slots based on trends, priorities, and funding. The purpose is to support transitions from institutions, align with the General Assembly budget allocations, and maintain sustainability of the program. Updates include increasing Money Follows the Person and state-funded conversions to support increased community transitions and maximize funding, increasing transitioning youth with reserve categories from the Community Supports Waiver, adding a new deinstitutionalization category for individuals that do not meet the Money Follows the Person requirements and maximizing funding, discontinuing the waiting list equity funds, which will be used to fund current services per the fiscal year 2026 budget bill, discontinuing the End the Waiting List Act categories, which does not have allocated funding to support. It is important to note each year hundreds of individuals are taken off the waiting list and enrolled in the waiver, exceeding these previous proposed figures. And finally, discontinuing the family support participants with increased need and community supports participants with increased need categories, as they are no longer needed with a consolidation of programs. I'm now going to turn it back over to Rhonda to share information about the next appendix. Next slide, please.
Thank you, Nova. So all federal Medicaid waiver program applications include details related to services which are noted within Appendix C, Participant Services. This is the largest appendix in the waiver document. Appendix C lists all waiver services and includes details related to service descriptions, service requirements, limitations, service delivery models, meaning whether the services can be self-directed or provided through the community provider managed service delivery model, and provider types and requirements. For this amendment, we've included service description proposals for each service that can be reviewed on the website. Next slide, please. In the following slides, we will talk about the proposed update changes to each service. Some updates that are being proposed would be applicable to all services. Others are specific to a specific service. Examples of updates that are applicable to all or most services include incorporating information from policy stat and DDA guidance into the service descriptions, clarifying that anyone paid to provide a Medicaid waiver service, including participant employees, are considered a Medicaid provider subject to all laws and regulations associated with the Medicaid provider. Remove the Deputy Secretary waiver of provider qualification standards and clarified Medicaid providers approved by the DDA must submit renewal applications at least 60 days prior to the expiration of their current approval. Next slide, please. CPR training must include a hands-on in-person component. At a minimum, employees must participate in an in-person skill session that will require them to show that they're able to perform CPR and first aid skills. And we've clarified that virtual supports has an electronic method of service delivery and associated requirements shared during the initial implementation. The waiver application includes a new section where this information is specifically noted. We've clarified service authorization and removed the words "unless otherwise authorized by DDA" language, and we removed language associated with legacy service transitioning to LTSS Maryland. As of September 2024, all DDA providers have transitioned to LTSS Maryland billing. We will now discuss some of the service-specific updates. Next slide, please. Nova, if you're talking, we're unable to hear you.
Thank you once again. Okay, so this slide shows the main update related to assistive technology and services. The purpose of assistive technology and services is to maintain or improve a person's functional abilities, enhance interactions, support meaningful relationships, and promote their ability to live independently and meaningfully participate in the community. For assistive technology and services, we are proposing the following updates. Adding language to clarify assistive technology and services can be used as a creative solution to help with a participant's health and safety, build relationships, and increase independence at home, in the community, or at work. Adding monthly service fees as a covered service. Removing personal emergency response systems as they are already covered under Community First Choice. Currently, there are a few individuals receiving personal emergency response system supports, or PERS, under the DDA-Operated Medicaid waiver programs. The DDA and Community First Choice program will coordinate and track the transition of personal emergency response system supports. Program case managers, coordinators of community services, and support planners will support participants and their teams with the transition. Case managers will create and/or review person-centered plans and plans of service to reflect the change in service program. And we're updating to adding Shift Enabling Technology certification as an acceptable certification for a qualified assistive technology specialist, which will expand the pool of qualified providers. Next slide, please. This slide shows the main update related to behavioral support services. Behavioral support services are an array of services to assist participants who, without such supports, are experiencing or are likely to experience difficulty at home or in the community as a result of behavioral, psychological, social, or emotional issues. These services seek to help understand a participant's communication and behavior, and its function is to develop a behavior support plan with the primary aim of enhancing the participant's independence, quality of life, and inclusion in their community. For behavioral support services, we are proposing the following updates. Improving quality of services by clarifying the behavioral assessment includes reviewing data and environments and record reviews and interviews with the participant and individuals supporting the participant with respect to possible reasons for the challenging behaviors, ways to support positive behaviors, and obtaining suggestions of positive and effective ways to communicate wants and needs and decrease challenging behaviors. We are also clarifying that recommendations for dedicated one-to-one and two-to-one support, enhanced supports, and overnight services must be in a behavior support plan, adding that expectations for dedicated supports to be part of the behavior support plan. Clarifying behavioral consultation includes graphing and analysis of collective data to identify trends and patterns of target behavior, and adding information from DDA policy and guidance, such as requirements for progress notes. We are also proposing to expand the pool of qualified providers by adding to the type of qualified professionals that can complete the behavioral assessment and provide consultations to include a licensed graduate level professional counselor working under the license of a licensed clinical professional counselor, licensed master level social worker working under the license of a licensed clinical professional counselor, and board certified behavior analyst. We are also removing the requirements for high school or equivalent hire for staff providing brief support implementation services. Next slide, please. This slide shows the main update related to career exploration, training requirements, required within 3 months of hire in the following. Career exploration are time-limited services to help participants learn skills to work towards competitive integrated employment. Career exploration includes facility-based supports, small group supports, and large group supports. For career exploration, we are proposing adding staff training requirements as noted in the Meaningful Day Services training policy. Examples include, but are not limited to, basics of employment first and customized employment, facilitation of natural supports and the principles of fading, the role of the job coach, basics of benefits awareness, and basics of self-employment. Next slide, please. This slide shows the main updates related to community development services. Community development services provide the participant with developmental and maintenance of skills related to community membership through the engagement in community-based activities with people without disabilities. For community development services, we are proposing the following updates. Adding that dedicated supports can be provided for participants new to services and participants in services who have a specific documented behavioral or health and safety needs for up to 6 months while the behavior support plan and nursing care plan gets authorized and developed. For people in self-direction, adding option to provide training and benefits, and adding staff training requirements as noted in the Meaningful Day Services training policy. Next slide, please. This slide shows the main updates related to community living enhanced supports and community living group home. Community living group home services provide the participant with development, acquisition, and maintenance of skills related to activities of daily living, instrumental activities of daily living, and socialization through application of formal teaching methods in a community residential setting. Community living enhanced supports participants who exhibit challenging behaviors or have court-ordered conditions for release or probation restrictions with development, acquisition, and maintenance of skills related to activities of daily living, instrumental activities of daily living, socialization, and safety of safe and others by providing additional observation and direction in a community residential setting. For community living enhanced supports and community living group home, we are proposing the following updates. We are adding language that dedicated supports can be provided for participants new to services and participants in services who have specific documented behavioral or health and safety needs for up to 6 months while a behavior support plan and nursing care plan gets authorized and developed. This allows participants to get necessary services during the development period, and it eliminates gaps in services. We are also adding requirements for overnight supports to be provided by staff that are awake and alert, ensuring health and welfare of participants. And we are removing requirements for staff to have a GED or high school diploma, expanding the pool of qualified providers. Next slide, please. This slide shows the main updates related to day habilitation. Day habilitation services provide the participant with the development and maintenance of skills related to activities of daily living, instrumental activities of daily living, and vocation and socialization through application of formal teaching methods and participation in meaningful activities. For day habilitation services, we are proposing the following updates. Adding language about dedicated supports can be provided to participants new to services and participants in services who have a specific documented behavioral or health and safety needs for up to 6 months while a behavior support plan and nursing care plan gets authorized and developed. Again, this allows participants to get necessary services during the development period and eliminates gaps in services. We are clarifying that day habilitation is separate and distinct service from residential service. And we are adding staff training requirements as noted in the Meaningful Day Services Training Policy. Next slide, please.
Thank you, Nova. This slide shows the main updates related to employment services. Employment services provides the participant with a variety of flexible supports to help the participant to identify career and employment interests, find and keep a job, including discovery, which is a process to assist the person in finding out who they are, what they want to do, and what they have to offer. Job development, which relates to supports in finding a job, including customized employment and self-employment. Ongoing job supports, which are various supports a participant may need to successfully maintain and advance their job. This includes nursing support services based on assessed need. Follow-along supports, which are periodic supports after a participant has transitioned into their job. Employment services also includes self-employment development supports, which are supports to assist a person whose discovery activities and profile indicates a specific skill or interest that would benefit them from resource ownership or small business operations. And employment services includes coworker employment supports, which are supports in a situation when an employer has identified that an on-site job coach would not be optimal, yet the participant could still benefit from additional supports. For employment services, we are proposing the following updates: adding information from DDA's policy and guidance, for example, incorporating information from DDA's Meaningful Day Service policy, including but not limited to clarified discovery milestone requirements. Clarifying job development includes strategic combination of both direct and indirect services. Clarifying job supports and follow-along supports can be provided via remote technology, for example, Skype or FaceTime, if preferred by the participant. Clarifying follow-along supports includes at least 2 direct face-to-face support contacts with the person in the course of the month, but it may also include other types of interventions, such as, but not limited to, phone calls to the person or the employer, and general coordination needed to support a person to maintain their employment. And we propose to incorporate information from the DDA's Competitive Integrative Employment Policy. We're proposing to clarify when seeking service authorization and or reauthorization for employment services through follow-along job supports or an ongoing job support that a participant's job must have the qualities of competitive integrative employment. For the provider managed service delivery model, we propose clarifying what the services may be authorized. For example, when a person who has newly added an employment goal, including participants new to services, employment services follow-along and ongoing job supports may be authorized even if the person is not currently employed. We also propose that participants who have been authorized employment services, such as follow-along and ongoing job supports, for one previous plan year without securing employment during that plan year may be authorized for one additional plan year, even if the participant is not currently employed. For those participants who've been authorized employment services for follow-along and ongoing job supports for 2 consecutive plan years without securing employment for those 2 consecutive plan years, they may not be authorized for services for any subsequent plan year unless the participant secures employment. For participants who are not currently authorized employment services, follow-along and employment services, ongoing job supports, if they then subsequently secure employment services during the course of their plan year, and this employment is assessed to require these services, the coordinator of community services must submit a revised plan, and the revised plan should be noted that the employment was secured and marked as an urgent plan. Next slide, please. This slide shows the update related to environmental assessments. An environmental assessment is an on-site assessment with the participant at their primary residence to determine if an environmental modification or assistive technology may be necessary in the participant's home. For environmental assessment services, we clarified that an authorized annual assessment is based on a plan year. Next slide, please. This slide shows the main update related to environmental modifications. Environmental modifications are physical modifications to the person's home based on an assessment designed to support the person's effort to function with greater independence or to create a safer, healthier environment. For environmental modification services, we are proposing to add smart home devices that require attachments to the home, such as voice-activated door openers, blinds and shade openers, and to streamline qualification requirements for a current license with the Maryland Home Improvement Commission or to be a Division of Rehabilitation Services approved vendor. Next slide, please. This slide shows the updates related to family and peer mentoring supports. Family and peer mentoring supports connects people and their primary unpaid family caregiver with mentors who have lived similar experiences. These mentors provide invaluable support in navigating systems, local resources, and community services while helping participants and their families build knowledge, skills, and confidence to achieve their goals and live their best life. For family and peer mentoring support services, we are proposing the following updates. Clarifying mentors provide support in navigating systems, local resources, and community services while helping participants and family members build skills and confidence to achieve their goals and live their best life. We're proposing that family mentors is provided to the participant's primary unpaid caregiver by a family member peer, while peer mentoring is provided by a person with a disability to the participant. And we propose eliminating the requirement for a bachelor's degree, highlighting the importance of lived experiences as a mentor. Next slide, please. This slide shows the updates related to family caregiver training and empowerment services. Family caregiver training and empowerment services provides education and support to the family caregiver of a participant that preserves the family unit and increases confidence, stamina, and empowerment to support the participant. Education and training activities are based on the family caregiver's unique needs and are specifically identified in the participant's file. For family caregiver training and empowerment services, we're proposing adding organized healthcare delivery systems as a new qualified provider option. Next slide, please. This slide shows the updates related to individual and family directed goods and services, often referred to as IFDGS. Overall, updates are meant to highlight community inclusion and independence. For individual and family directed goods and services, some of the proposed updates are clarifying the extent of goods and services allowable in line with the Center for Medicare and Medicaid Services Waiver Technical Guide. As per the Center for Medicare and Medicaid Services Technical Guide, goods, services, equipment, and supplies that are diversional or recreational in nature fall outside the scope of the Medicaid 1915C of the Social Security Act. Goods, services, equipment, and supplies that a household that does not include a person with a disability would be expected to pay as a household expense, such as subscriptions to cable television services, etc., are not covered. In alignment with these requirements, we are also proposing language to better clarify recreational events and associated costs and accessories. For example, clarifying tickets, memberships, and related costs to attend recreational activities and events, such as museums, zoos, bowling, and indoor skydiving, are not covered. For some items, there is a proposed cap. Some examples must be related to the person's disability, and some items must be recommended by a medical professional. All items must not be covered by insurance or other resources. We are also clarifying dental services recommended by a licensed dentist and not covered by health insurance, such as dental anesthesia and dental services, are covered. Next slide, please. We are also proposing adding person must first access integrated programs or activities that are available to the public, free or at a lower cost. Programs and activities that are exclusive for individuals with disabilities are not covered. We are clarifying goods and services must be the most effective way of meeting the participant's need. Clarifying that reimbursement is based on reasonable and customary fees, and clarifying that goods, services, equipment, and supplies cannot pay for common household expenses. We are also clarifying that DDA cannot pay for items or services purchased prior to DDA's approval of the individual and family directed goods and services request. Items and services must be reimbursed based on those reasonable and customary standards. This refers to prices or fees that are considered fair and typical for a service or provided. And clarifying that individual and family directed goods and services requests cannot be submitted if the participant does not have an active and approved initial, revised, or annual self-directed person-centered plan. Next slide, please. In terms of day-to-day administrative supports, we have clarified that day-to-day administrative supports provides assistance with participants who self-direct their services with household management and scheduling medical appointments. As per the bill, we have added day-to-day administrative supports as a specific service which funding may be authorized. We consulted with the Center for Medicare and Medicaid Services, who advised us to keep the service within the individual and family directed goods and services. We have created a new person-centered plan drop-down service option similar to the standalone staff recruitment and advertisement. Day-to-day administrative supports will have its own unique billing procedure code and drop-down option. The service description includes information regarding a decision tree checklist. This information was drafted based on a discussion with a self-directed advocacy network of Maryland advocate. The decision tree checklist is used to identify 1, task a participant can do for themselves with or without assistance from others. 2, supports and training to help participants learn to complete tasks themselves. 3, current team members, Medicaid services, and local, state, and federal resources that can assist with the task. And 4th, unmet needs that a day-to-day administrator can provide within the scope of the approved waiver service. In line with the Center for Medicare and Medicaid Services guidance, day-to-day administrative supports may be authorized if the supports needed is not available under another Medicaid state plan or Medicaid waiver service. For example, not available under coordination of community services, housing support services, personal supports, community development services, support broker services, financial management and counseling services, and health choice special needs coordinators. Next slide, please. Day-to-day administrative supports does not include making payments for household management care, such as repairs, snow removal, and lawn care, making decisions for the participant, approving and signing timesheets or vendor provider invoices, personal support services, including budgeting and money management, maintaining a home, such as cleaning out the refrigerator, ensuring paper products, etc., meal preparation, personal care, house cleaning chores, laundry, and overnight supports. It does not include developing staffing schedules and cleaning schedules, which can be supported by team members, support brokers, and personal support service staff. It does not include financial management, such as maintaining benefits and Medicaid eligibility, For example, food stamps, Medicaid waiver, that are supported by coordinators of community services, benefit counselors, and other resources. It does not include money management and property management, which can be provided by guardian of property or representative payees. A guardian of property is someone that the court names to manage money and property for someone else who the court has found cannot manage their money and property alone. A representative payee, often shortened to referred to as a rep payee, is an individual or organization appointed by the Social Security Administration to receive and manage Social Security or supplemental income benefits on behalf of beneficiary who is unable to manage their own finances. This service does not include the development of a person-centered plan, an emergency plan, or staffing backup plan, which is directed by the participant and their legally authorized representative, facilitated by the coordinator of community services with support from the team, including support brokers. And it does not include assistance with recruitment and hiring direct support professionals, managing workers, terminating workers, and providing information on effective communication, problem solving, and conflict resolution, which is provided with support broker services. Next slide, please. This slide includes information related to limits for individual and family directed goods and services. The Budget Reconciliation and Finance Act of 2026 requirements removes the restriction to funding limits for the individual and family directed goods and services. The DDA is reinstating the previous limit of up to $5,000 per year from the total self-directed budget for goods and services. Participants currently approved individual and family directed goods and services above this limit can continue to utilize the authorized amount through the end of their plan year. This limit does not include funding associated with the day-to-day administrative supports. Day-to-day administrative supports must be reasonable and may be provided up to 10 hours per month. This is based on the funding authorized by the General Assembly that can support up to 10 hours per month per participant. To ensure quality services, day-to-day administrative support providers can provide collectively for all participants they support up to 40 hours per week of day-to-day administrative supports. Next slide, please. We are also proposing provider qualifications for day-to-day administrative supports. Day-to-day administrators must be 18 years of age, pass criminal background investigations, and live in Maryland. A legally responsible person and legal guardian of the participant cannot be paid by the Medicaid program to provide this Medicaid waiver program service. Relatives can provide the service if they are not a legal guardian or legally responsible person. We look forward to receiving your input on the proposals related to day-to-day administrative supports. Next slide, please.
Thank you, Rhonda. This slide shows the updates related to live-in caregiver supports. The purpose of live-in caregiver supports is to pay a portion of the cost of rent and food that can be reasonably attributed to a live-in personal caregiver who is residing in the same household with the participant. For live-in caregiver supports, we are proposing the following updates. We are clarifying a live-in caregiver is defined as someone who is residing in the same household with a participant who that is also providing supports and services in the participant's individual's home. We are clarifying reimbursement is for the months in which the service agreement was successfully carried out. When entering into the service agreement with the caregiver, The participant will take on the risk for all unmet rental obligations. And we are clarifying that siblings may be paid to provide this waiver service unless they are a legally responsible person or legal guardian. Next slide, please. This slide shows the updates related to medical daycare. Medical daycare services provide medically supervised, health-related safeties services in an ambulatory facility setting, as defined in the Code of Maryland Regulations 100907. Medical daycare includes the following services: healthcare services, nursing services, physical therapy services, occupational therapy services, assistance with activities of daily living, such as walking, eating, toileting, grooming, and supervision of personal hygiene, nutrition services, social work services, activity programs, and transportation services. For medical daycare, we are proposing the following updates: that behavioral support services may be provided at the same time as medical daycare if there is a documented need. Next slide, please. This slide shows the updates related to nursing support services. Nursing support services provide a registered nurse licensed in the state of Maryland to perform nursing consultation, health case management, and delegation services based on the participant's assessed need. Services do not include private duty nursing. For nursing support services, we are proposing to clarify health case management does not include delegation of medications and medical, health, nursing treatments provided by paid staff. We are also proposing to remove the requirement for 24/7 availability or provide qualified backup services as clarified as per Code of Maryland Regulations 10.27.11. The delegating nurse shall be readily available when delegating a nursing task to an unlicensed individual, certified nursing assistant, or Medicaid technician, and to address the participant's health needs as may arise emergently. Next slide, please. This slide shows the updates related to participant education, training, and advocacy supports. Participant education, training, and advocacy supports provides funding for the costs associated with training programs, workshops, and conferences to assist the participant in developing self-advocacy skills, exercising civil rights, and acquiring skills needed to exercise control and responsibility over other support services. For participant education, training, and advocacy services, we are proposing the following updates: to remove the individual participant support professionals and added organized healthcare delivery system as a qualified provider, and clarifying a legally responsible individual, legal guardian, or a relative of a participant may not be paid to provide this service, as the service is paying of training programs, workshops, and conferences. Next slide, please. This slide shows the updates related to personal supports. Personal supports provides habilitative services and overnight staff support to assist participants who live in their own or family homes with acquiring, building, or maintaining the skills necessary to maximize their personal independence. These services include in-home skills development and community integration and engagement skill development supports. For personal supports, we are proposing the following updates. Adding that the DDA may authorize an enhanced rate, 2-to-1, and overnight services for participants new to services and participants in services who have a specific documented behavioral or health and safety need for up to 6 months while a behavior support plan and nursing care plan gets authorized and developed. Adding that personal supports enhanced cannot be provided virtually. Adding requirements that overnight staff must be alert and awake. Removing limitation of 82 hours for traditional provider model. And clarifying that legally responsible persons, legal guardians, and relatives may not be paid for greater than 40 hours per week for services. Next slide, please. This slide shows the updates related to remote support services. Remote support services provide oversight and monitoring within the participant's home through an off-site electronic support system in order to reduce or replace the amount of staffing a participant needs while ensuring the participant's health, safety, and welfare. The purpose of remote support services is to support the participant to exercise greater independence over their lives. It is integrated into the participant's overall support system and reduces the amount of staff support a person uses in their home while ensuring health and welfare. For remote support services, we are proposing updating the service definition to include that remote support services allow the participant with the options to have control over the equipment, including the ability to turn off remote monitoring device or equipment if they choose to do so, unless otherwise noted in their behavior support plan or nursing care plan. This gives participants great autonomy and flexibility over their life. Next slide, please. This slide shows the updates related to respite care services. For respite care services, we are proposing the following. We are clarifying respite purpose is to provide the primary caregiver and the participant with a break from their daily routines. We are clarifying respite may not be provided by the primary caregiver. We are removing day trips as an allowable service component. We are adding that state respite camps must be certified by the Maryland Department of Health, and clarifying out-of-state camps may be approved by DDA based on state licensure requirements. Next slide, please.
Thank you, Nova. This slide shows the update related to support broker services. Support broker services provides information and assistance in support of self-direction. Support broker services is used to provide information to ensure that participants understand the responsibilities involved with directing their services, and they assist the participant in developing the skills necessary to independently direct and manage their Medicaid waiver program services and providers, including employees, vendors, and DDA providers, as the employer of record. Proposed updates to support broker services include updating the service definition and description requirements based on the Federal Center for Medicare and Medicaid Services Technical Guide. The updates are to simplify the information and to prevent duplication of activities with case managers and day-to-day administrative supports. Clarifying that support brokers may provide supports for reviewing and timesheets and invoices, but the participant always makes the decision. Adding requirements for support brokers to sign and adhere to a code of conduct. Clarifying that support brokers' administrative non-billable activities, which include attending trainings, correspondence or research, creating and issuing invoices, and travel. Clarifying that individuals and organizations providing support broker services may provide no other paid service to the DDA-operated Medicaid waiver participant. And to ensure quality services, adding support brokers can provide collectively for all participants they support up to 40 hours per week of support broker services. Next slide, please. We are also proposing updates to support broker services to include clarifying initial orientation assistance authorized up to 15 hours for the first month when enrolled, enhancing qualified providers to include required training in the code of conduct, removing requirements for first aid and CPR, clarifying that support brokers must satisfactorily complete all DDA required support broker trainings and requirements, and clarifying a designated representative may never be a support broker for the participant. Next slide, please. This slide shows the updates related to supported living services. Supported living services provides participant with a variety of individualized services to support independent living in the community. Here again, we are proposing that DDA may authorize dedicated supports for participants new to services and participants in services who have specific documented behavioral or health and safety needs for up to 6 months while a behavior support plan and nursing care plan gets authorized and developed. We are also adding the requirement that overnight staff must be alert and awake. Next slide, please. This slide shows the update related to transition services. Transition services provide certain funding for allowable expenses related to participants moving from one, an institutional setting to a group home or private residence in the community for which the participant or their legal representative will be responsible, or two, a community residential provider to a private residence in the community for which the participant or their legally responsible or their legal representative will be responsible. For transition services, we propose to add that this service to include the cost of training direct support professionals who will be supporting participants with complex medical or behavioral needs prior to transition date to ensure health and welfare on the first day of community services. And we've removed the individual provider type as organized healthcare delivery system would pay for services. For services provided under the self-directed service delivery model, it is important to note that the financial management and counseling service providers are organized healthcare delivery systems. Next slide, please. This slide shows the update related to transportation services. Transportation services are designed specifically to improve the participant and the family caregiver's ability to independently access community activities within their own community in response to needs identified through the participant's file. For purposes of this Medicaid waiver program service, the participant's community is defined as places the participant lives, works, shops, or regularly spends their day. The participant community does not include vacations in the state. For transportation services, we propose to provide supports within the participant's community and remove day trips as an allowable service component. Next slide, please. This slide shows the updates related to vehicle modifications. Vehicle modifications are adaptations or alterations to a vehicle that the person's primary means of transportation. Vehicle modifications are designed to accommodate the needs of the person and enable the participant to integrate more fully into the community and to ensure health, welfare, and safety and integration by removing barriers to transportation. For vehicle modification, we propose to clarify that this service does not include charging electric vehicles. Next slide, please.
So this slide shows the updates related to Appendix C1 and 2 through 5. In these sections of Appendix C, we propose some updates and some clarifying language, including adding coordinators of community services training requirements in alignment with Code of Maryland Regulations 100948. Training includes expectations related to integration and full access to the greater community, community settings rule, and person-centered planning. We are also proposing to add information related to virtual supports. The Center for Medicare and Medicaid Services added a new section to the waiver application in Appendix C titled Remote/Telehealth Delivery of Waiver Services. States are required to specify whether each waiver service that is specified in Appendix C1-C3 can be delivered remotely via telehealth. We have included information regarding the virtual supports, which are an electronic method of service delivery. Virtual supports are used to facilitate community integration, enhance the effectiveness of service delivery, improve accessibility, and ensure health and safety. We have also added information related to the Quality Improvement Organization, quality reviews, and auditing of provider qualifications. Rhonda, can I turn this over to you? I'm having computer difficulties.
Yes, Nova, that would be great. Okay. So this slide relates to Appendix C-1 and 2-5. We are proposing adding the coordinators of community service training requirements noted in COMAR, the Code of Maryland Regulations 100948. Training includes that expectation related integration and full access to a greater community setting rules, and person-centered planning. We are also adding information related to virtual supports. As Nova's mentioned, I want to reinforce that the Center for Medicare and Medicaid Services added a new section to the waiver application in Appendix C titled Remote/Telehealth Delivery of Waiver Services. States are now required to specify whether each waiver service that is specified in Appendix C-1, C-3 can be delivered remotely or via telehealth. We have included information regarding the virtual supports, which are an electronic method of service delivery. Virtual supports are used to facilitate community integration, enhance the effectiveness of service delivery, improve accessibility, ensure health and safety. We've added information also related to the quality improvement organization in terms of their quality reviews and auditing provider qualifications. Next slide, please.
And I'm back up so I can take it over again.
Okay, thank you.
Okay. Appendix C5 has to do with general waiver service specifications. Specifically, this section discusses the state's assurances regarding extraordinary care, payments for services by relatives, legally responsible persons, and legal guardians, and criminal background check requirements. The Center for Medicare and Medicaid Services waiver notes extraordinary care, which means exceeding the ordinary care that would be provided to a person without a disability or chronic illness of the same age, and which are necessary to assure the health and welfare of the participant and avoid institutionalization. For extraordinary care, DDA updates include identifying the scope of legally responsible individuals, relatives, and legal guardians in providing extraordinary care. It also expands the current definition of relative to include a grandparent, step-grandparent, sibling, step-sibling, aunt, uncle, niece, and nephew, and clarifies service provided by a legally responsible person, relative, or legal guardians is subject to the same person-centered plan and claims monitoring procedures that are applied to all Medicaid waiver services. Next slide, please. Next, oh, thank you. The Center for Medicare and Medicaid Services, added additional waiver application requirements related to the provision of extraordinary care, legally responsible persons, legal guardians, and relatives. The Center for Medicare and Medicaid Services, Appendix C 2 through 5, waiver requirements include details regarding the state policies to determine that the provision of services by a legally responsible individual, legal guardian, and relatives is in the best interest of the participant, and the state processes to ensure that legally responsible individuals, legal guardians, and relatives who have the decision-making authority over the selection of waiver service providers use substituted judgment on behalf of the individual. Next slide, please. Additional Center for Medicare and Medicaid Services Appendix C 2 through 5 waiver requirements include details regarding limitations on the circumstances which payment will be authorized or the amount of personal care and other services for which payment may be made, safeguards the state implements when services are provided, and the procedures that will be used to implement required state oversight. Next slide, please. Also, in response to the Center for Medicare and Medicaid Services additional waiver application requirements related to the provision of extraordinary care, legal responsible persons, legal guardians, and relatives, we're proposing updating the service delivery by a legally responsible person, legal guardian, and relative to address the requirement to ensure that individuals, legal guardians, and relatives who have decision-making authority over the selection of waiver service providers use substituted judgment on behalf of the individual. There is language around conflict of interest. We added that legally responsible persons, legal guardians, and relatives providing services cannot make decisions regarding service delivery, including wage rates, hours of service, etc. And we added that participants must have a signed-supported decision-making agreement to support making individual independent decisions regarding service delivery. Next slide, please. Okay. We have also defined emergency, unplanned departures, and temporary exceptions. Brief or temporary exceptions are authorized for up to 90 calendar days in any fiscal year in the event of an emergency or unplanned departures. Proposed updates in this section include participants are required to access their backup plan and emergency plans prior to seeking exception to the 40-hour limit. And participants may submit a request for overtime. The request has to be approved before services are provided. Emergency or unplanned departures include unexpected circumstances, such as inclement weather, sudden illness, or the unplanned extension of medical leave that prevents a worker from arriving at the job site, and where another worker or unpaid caregiver is not immediately available to work. It includes sudden illness or the unplanned sickness of a participant, the sudden loss of an unpaid caregiver, which kept the provision of paid services by relatives and legal guardians at or below 40 hours per week, or a worker unexpectedly quits or is terminated from employment such that the relatives or legal guardians must perform paid work in excess of the 40-hour limitation, sudden notification of an employee's request to access unpaid leave, emergency termination of an individual due to fraud, waste, or abuse, or the inability to hire employees. To address this requirement, to determine that the provision of services by a legally responsible person, legal guardian, and relatives is in the best interest of the participant, we have added that a request form is required for authorization before a legally responsible person, legal guardian, or relative provides these services. Effective April 1st, 2026, participants seeking to use a legally responsible person to provide services must submit a request form. Next slide, please. The Center for Medicare and Medicaid Services also added additional waiver application requirements related to the state option to provide HCBS in acute care hospitals in accordance with Section 1902 H1 of the Act. Specifies whether a state chooses the option to provide waiver HCBS services in community care hospitals, in acute care hospitals. Under this provision, direct support services may be provided in an acute care hospital if the purposes of supporting the person's personal, behavioral, and communication supports not otherwise provided in that setting. These supports assist a participant in communicating their needs and utilizing behavior strategies to support healing, use of medical strategies to address the acute care health issues, and discharge to their community. We are adding specific information about the DDA services that can be provided in acute care hospital settings and when direct support may be provided in those settings to support the participants' personal, behavioral, and communication supports not otherwise provided in that setting. The DDA-Operated Medicaid Waiver Program currently provides the opportunity for the following waiver services: community development services, day habilitation services, personal support services, community living group home services, and community living enhanced support services, and supported living services. We also clarified that safeguards related to participant satisfaction, health and welfare through coordinators of community services, quarterly monitoring and follow-up activities. Next slide, please. Appendix D, Participant-Centered Planning and Service Delivery. This appendix outlines the state's responsibilities for ensuring that waiver participants receive services based on a person-centered planning process. This process ensures that individuals have a say in their care and receive services tailored to their needs, goals, and preferences. Next slide. For Appendix D, we are proposing the following updates. Adding Coordinator of Community Services Monitoring, competency-based skills, and knowledge requirements per Code of Maryland Regulations 1009-48. Coordinators of Community Services must monitor service delivery in person at the place of service as specified in the approved person-centered plan. The coordinator of community service should visit the participant in the setting of the service and, for each quarterly visit, a different service setting. We clarify that the coordinators of community service cannot provide to a participant as the participant's employee or as the employee of a vendor or provider, which includes conflict-free case management. Adding language about sharing information about the self-directed orientation, training, and exploring assistive technology, and updating performance measures to include information gained from the National Core Indicators in-person surveys and the Quality Improvement Organization targeted case management reviews. Next slide, please.
Thank you, Nova. Now let's review some updates to Appendix E, Participant Direction of Services. This appendix outlines the state's responsibilities when participants are given the option to self-direct their services. Next slide, please. Within Appendix E, we are proposing clarifying that financial management and counseling services providers must provide timely responses and resolutions to participants' requests, and clarifying that non-disclosure agreements with participants associated with the Medicaid Waiver Program services are prohibited for all providers of services and supports, including employees, vendors, DDA Medicaid providers, coordinators of community services, and financial management and counseling service providers. Next slide, please. We're proposing updating safeguards to include the coordinator of community services, quarterly visits, and more frequently as needed, including wellness checks. The DDA regional office staff, site visits, including quality enhancement and nurses to follow up on health and safety concerns and reported complaints and incidents, and updating safeguards to note that the Office of Healthcare Quality to conduct site visits and investigations based on complaints and investigation or incidents reported. Next slide, please. We are proposing updating information related to terminating the participant's enrollment in the self-directed service delivery model. Specifically, when participants overutilize authorized services, before involuntarily terminating the person from the self-directed model, the DDA may first require the person to meet with DDA and their team to review rights and responsibilities, including the monitoring and usage of funding for authorized services, and or require a corrective action plan. Next slide, please.
So Appendix F, participant rights. This appendix outlines the state's responsibilities to ensure that waiver participants' rights are protected and they are safeguarded from abuse, neglect, and exploitation. Next slide, please. This slide shows the update related to Appendix F, participant rights. For Appendix F, we are proposing the following: to include the new dedicated Request a Fair Hearing File and Appeal website, which includes plain language information, frequently asked questions, and an option to submit fair hearing requests online. The Maryland Department of Health has a new dedicated website which includes information related to your fair hearing rights, notice of hearing date and location, what to expect before a hearing, during the hearing, and information about the hearing, decision, frequently asked questions. The website includes the option to submit a fair hearing request online for anyone applying for or enrolled in Medicaid who thinks a decision to deny, suspend, end, or reduce their Medicaid eligibility or services is wrong, has the right to ask for a fair hearing at the time of that decision, and the ability to submit a request for fair hearing via mobile request form. We added the link to the webpage on this site. We are also updating the case resolution conference to be specifically related to DDA eligibility determinations. Next slide, please. So this is Appendix G, Participant Safeguards. The appendix outlines the state's responsibilities for ensuring participant safety and service continuity during emergencies, disasters, or other disruptions. Next slide, please. For Appendix G, we are proposing the following. The DDA added language about the Quality Improvement Organization and their role in quality monitoring, quality assurances, and evaluation compliance. The DDA's designated Quality Improvement Organization evaluates and develops continuous quality enhancement processes related to performance. Its role is to support the DDA to identify gaps in system performance, guidance and policy, and performance measures related reporting in an effort to provide quality enhancement strategies that support improved system performance. To do this, the Quality Improvement Organization provides health and welfare reviews and conducts utilization reviews. We clarified the Office of Healthcare Quality has the authority to investigate all incidents and all types of providers, including employees, vendors, and DDA providers. We clarified the DDA website homepage includes a link to information on how to report abuse, neglect, or concerns. The link is included on this slide. We updated performance measures to include information gained from the National Core Indicators in-person surveys and Quality Improvement Organization health and welfare reviews. Next slide. Appendix H, System Improvement. This appendix outlines how the state ensures compliance with federal requirements, monitors service delivery, and improves the quality of services for waiver participants. The state must implement a quality improvement strategy to monitor and enhance waiver services. Next slide, please. This slide shows the updates related to Appendix H, Quality Improvement Strategy. For Appendix H, we identified work being done on system improvements and quality enhancements. We are proposing clarifying DDA Waiver Advisory Council with the purpose of creating meaningful engagement and feedback loop with all interested stakeholders and with a focus on people with lived experience. Participants will have the opportunity to advise in and provide recommendations to the DDA on system design, service delivery, and quality enhancement strategies for the DDA-operated Medicaid programs. We're clarifying that the Quality Improvement Organization evaluates and develops continuous quality enhancement processes related to its performance. Its role is to support the DDA to identify gaps in system performance, guidance and policy, and performance measure reporting in an effort to provide quality enhancement strategies that support improved system performance. And we're adding additional information related to the DDA seeking to achieve network accreditation from the Council on Quality and Leadership. Achieving network accreditation uses baseline performance and seeks system transformation by enhancing outcomes people experience. And measurable progress is identified through data collection efforts using the Council on Quality and Leadership's basic assurance reviews and personal outcome measure interviews. Next slide, please. Thank you. Appendix I, Financial Accountability. This appendix outlines the financial accountability responsibilities of the state. It details how the state ensures proper financial management. It discusses rate-setting methodologies, billing and payment procedures, and financial safeguards. Appendix J, Cost Neutrality Demonstration. This appendix outlines how the state demonstrates that the waiver is cost neutral during each year. The state must ensure that the waiver does not cost more than institutional care over the life of the program. Next slide, please. This slide shows the updates related to Appendix I and J. Updates include adding day-to-day administrative supports and assistive technology monthly service fees, user and service projections. Clarifying medical daycare claims are submitted electronically for payment in the state's e-Medicaid system, which interfaces with the Medicaid Management Information System, or MMIS, and updating performance measures. Next slide, please. It also includes updating assumptions, estimated users, average costs, average units, and total costs based on the waiver consolidation, and adding language to address the cost containment strategies from the fiscal year 2026 legislative budget bill. Specifically, we added based on budget allocations, rates may be funded at a percentage of the fully loaded brick up to 100%. In addition, the geographical differential rates may also be funded at a percentage above the standard rates. As required by fiscal year 2026 budget bill, in waiver year 3, the budget includes geographical differential rates of 10% above the standard rate for eligible services. Next slide, please.
Thank you, Nova. This slide relates to the federal requirement for cost neutrality. The state must demonstrate that the waiver program is cost neutral. This means the cost of Medicaid waiver services cannot cost more than the cost of providing institutional services. As noted in federal law, the Federal Secretary for Health and Human Services must monitor the implementation of waivers granted under the 1915 authority. This is to assure that the requirements for Medicaid waiver programs are being met and shall, after notice and opportunity for a hearing, terminate any waiver where there is noncompliance. Participant service utilization continues to grow, and many individuals' actual costs are exceeding institutional costs. We are seeing increased participation in our self-directed service delivery model, increased family members as paid staff, and family as paid staff at higher rates. Next slide, please. Each waiver cycle is for a 5-year period. In fiscal year 2026, which is July 2026, will be the beginning of the DDA-Operated Medicaid Waiver Program's 3rd waiver year. Historic projections included non-allowable facility costs and state-funded services. Some individuals receiving services at the Maryland State Residential Centers also received state general funds to support them in day habilitation services. The DDA asked the University of Maryland, Baltimore County, the Hilltop Institute, to conduct an actual cost analysis. The Hilltop Institute has demonstrated in their analysis cost neutrality compression for fiscal year 2026 through fiscal year 2028. This means there are narrow cost difference margins of approximately $35,000 for the remaining 3 years. Continued increased cost for services puts the program at risk of violating cost neutrality. Continued increased cost for services risk violating that cost neutrality and termination of the program under the current federal administration. This means that the program's $1.6 billion in general funds would be at risk. Next slide, please. This slide is a visual of the cost neutrality cost compression. Waiver services, which are reflected here by the blue bars, are trending closer and closer to the institutional cost, which is the yellow orangish line that's going across. Next slide, please. So in summary, we have shared an overview of amendment proposals, specifically to streamline and enhance the service delivery by merging the waivers into a single comprehensive program under the Community Pathways Waiver. By merging the 3 programs, all participants will have access to the full array of support services, meaningful day services, and residential services based on assessed needs. This will improve efficiency, ensure equitable access, provide a more person-centered approach to supports, and increase timely access to services. Having one program will also reduce the duplicative processes currently impacting staff resources with the Eligibility Determination Division, regional offices, financial management counseling service providers, and coordinators of community services. The amendment will ensure greater transparency, streamline service delivery, ensure funding is outcome-driven and sustainable, meet federal assurances, and reinforce regulatory compliance within the Medicaid waiver program for both service delivery models. Again, this also includes reducing the risk of federal audits and recruitments from audits and/or under the new federal administration. Next slide, please. We'd now like to share some information regarding additional stakeholder engagement and the public comment process. Next slide, please. This slide includes information about additional engagement, dates, and topics. Today, we shared an overview of the waiver amendment proposal. We will also review topic-specific information shared today during today's webinar on June 17th. We will review the waiver application overview and the input process tomorrow from 9 to 10:30. From 12 to 1:30, we will also be reviewing information related to self-direction. And then beginning at 2:30, we will review information related to services and provider qualification. So we'll be reviewing information we shared today, tomorrow in smaller meetings and sessions. We will also include additional opportunities for questions and answers. Next slide, please. This slide includes additional information regarding the public comment process. The official public comment period is from June 9th through July 8th, 2025. Track change documents regarding the amendment proposals are on the DDA Waiver Program website page. If you need a paper copy, please send a request to the email address wfb.dda@maryland.gov. Public comments can be submitted to the dedicated waiver email address wfb.dda@maryland.gov, or you can mail to DDA Federal Programs at 201 West Preston Street, 4th floor, Baltimore, Maryland, 21201. To be considered, all public comments must be submitted by 11:59 p.m. on July 8th. We're now going to open up and review questions that have been submitted in our chat, facilitated by Dr. Smalls. Next slide, please.
Okay, thank you, Rhonda. We got quite a few questions, and I will try to get through as many as we possibly can. Our first question is, when would the amendments be effective?
Thank you, Dr. Smalls. The amendments would be effective October 6, 2025.
Thank you. The next question is, how will GTI move us from one waiver budget to another in an effective way so that we don't lose ability to pay staff?
Thank you, Dr. Smalls. So with the consolidation of the waiver programs, the program names will be updated. The budgets will remain the same. If you have questions specifically related to a current situation with your budget, please reach out to GTI's customer service to support you.
Thanks, Rhonda. Is it correct that the dates of the waiver going into effect is on 10/6/25 and public comment is until July 8th, 2025?
Yes, that is correct. The proposed effective date for many of these changes will be October 6, 2025, and the public comment period is from June 9th, 2025 through July 8th, 2025.
Thanks, Rhonda. And ask for a reminder on what's happening tomorrow, please.
Yep. For tomorrow, we will be reviewing the information that we shared today. We have broken it up into three focused topic areas. So beginning at 9 o'clock, we will be providing and reviewing the slides related to the waiver application overview and the input process. Beginning at noon, we will be reviewing information related to self-direction. So that'll include support broker services, individual and family directed goods and services, and Appendix E. And then at 2:30, we will review all the services and provider qualifications that were shared today under the Appendix C slides.
Thanks, Rhonda. The next question is, when does the reduction to the geographic differential go into effect, 7/1 or 10/6 with the other waiver changes?
Yep, good question. So the waiver amendment includes that information, and so that would go into effect on October 6, 2025.
Okay. If someone in the community supports waiver is planning on requesting community pathways because they need residential services, will they be able to access CP residential starting on 10/6 when the amendment goes into effect?
That's a very good question. So individuals who have an assessed need for residential services that meet the service definition and requirements for residential services can work with their coordinator of community services to submit a person-centered plan. We will be capturing information related to these requests, and they can be authorized so that services can begin in October based on assessed need.
Thanks, Rhonda. Does this mean minors will be able to enroll in residential services if there's a justified assessed need?
That's a good question. The service descriptions note that residential services are available for individuals 18 years of age and older.
Okay. How many slots were there in the CSS waiver and the family supports waiver, and does that compare to the new total slots with the merging into one community pathways waiver?
Yeah, that's a great question. Yes, the slots that are currently authorized in the community supports waiver and family supports waiver were reviewed for the amendment and proposal. All current participants will be transitioned over to the community supports waiver. Will be transitioned all to the community pathways waiver and do not need to reapply. We also evaluated the various types of slots, and Nova walked us through the different categories for which reserved categories will continue and which will end. For example, the waiting list equity funding slots will no longer be used because of the legislation that was passed authorizing the use of that funding for existing services. And so we have done a crosswalk from that to evaluate not only to ensure we have spaces and slots for current participants during the consolidation, but also consideration for the transitioning youth and other slot categories.
Thanks, Rhonda. The next question is, have you considered the possible overlap between the community pathways waiver and the autism waiver for individuals younger than 21 years?
Yeah, that's another good question. Just to note that individuals can be enrolled in one Medicaid waiver program at a time. The state of Maryland operates 8 different home and community-based 1915C waiver programs, and therefore individuals enrolled in the autism waiver would not be eligible or enrolled in a DDA-operated waiver program. If they are offered the opportunity to apply to a DDA-operated Medicaid waiver program, the individual, with the support of their family and team, would then need to make a decision of which Medicaid waiver program met their needs best. So they can be either enrolled in the autism waiver or, if offered the opportunity, the DDA-operated Medicaid waiver program.
Thank you. How is the cost of institutional care calculated for comparison on cost neutrality?
Yep, that's a great question. So the institutional care for the DDA-operated Medicaid waiver programs are intermediate care facilities for individuals with intellectual and developmental disabilities. In the state of Maryland, we refer to them as our state residential centers. So this would include the Holly Center and the Potomac Center. And so the Hilltop Institute with the University of Maryland, Baltimore County, looked at the actual Medicaid claims for services delivered to individuals in the state residential centers, in addition to any Medicaid services such as their pharmacy, their doctors, and compared that to actual waiver service claims for individuals in the waiver program, in addition to any Medicaid state plan services for doctors, pharmacies. So you compare the institutional costs for direct services compared to the waiver service direct service cost, and that's how you determine whether the cost neutrality standard is being met.
Thanks, Rhonda. A few individuals graduate from high school at 18. Will these students be eligible to transition directly into Community Pathways waiver after graduation, or will they still be required to wait until their designated transitioning youth year at 21?
It's another great question. If the individual is graduating at age 18 and does not meet any of the current reserve categories for the waiver program, they include transitioning youth, for which they would need to be at the age of 21. But we also have other reserve categories such as emergencies, people leaving institutions, etc. So if they do not meet any of those opportunities, then the individual may not be provided the opportunity to apply when they leave or graduate from high school at age 18.
Thank you. What about waiver re-enrollments for people who fall out of MA through no fault of their own? For example, submitted their redetermination packet before the deadline, but was not processed by EDD.
Yeah, it's a good question. Individuals, first of all, we want to encourage everybody, if they receive a letter or notification about a redetermination, to work with their coordinator of community services to gather those documents and information and submit to the department. If you receive a notice that you're being disenrolled, you have the ability to appeal that decision. Nova shared today that we're adding the link to the online appeal request form. With the timely appeal, your services will continue. If you have questions related to that, your coordinator of community services can follow up. And I know our Medicaid partners are also available to follow up on redetermination related questions.
Thanks, Rhonda. Regarding disenrollment, can an individual be disenrolled for asking too many questions on the DDA self-direction leadership? Can an individual be disenrolled if they submit a special request for family overtime 2 times in a fiscal year? Sorry, that's 2 questions.
Yeah, the answer to both of those questions are no. An individual would not be disenrolled for any of those reasons.
Okay, next comment. MD Think has been unworkable for me. The case manager was challenged to access the uploaded waiver redetermination application. Um, it looks like this is a very specific one. How will you fix some of the challenges so that participants and their families can complete and submit their redetermination application as required? This may require.
Thank you, Dr. Smalls, for sharing that. Thank you also for sharing challenges that you may be experiencing with the MD Think system. We will share this concern with our Medicaid partner who works directly with the Department of Human Services, who oversees the MD Think system, so that we can seek additional support and resources to support all stakeholders related to the use of the MD Think system for redeterminations.
Okay. What is the waiting list equity funds?
Yep, that's a great question. So the waiting list equity fund, as per the Maryland statute currently, is noted to support people who are in crisis and need emergency services, including people on the waiting list and individuals transitioning from the state residential center. So there is a funding source that is identified when people leave the state residential center, if there's any cost savings, and those funds could be available to support people on the waiting list. During the last legislative session, a decision was made to utilize those funds in that particular budget to support some of the ongoing cost of services for people currently enrolled in the DDA-operated waiver programs.
Thanks, Rhonda. Under Appendix C, clarifying that all individuals paid to provide Medicaid waiver services are considered to be a provider, does this apply to self-directing employees? Will there be a certification process?
It's a good question. In working with the Center for Medicare and Medicaid Services, they have advised that anyone paid to receive Medicaid funding is considered a Medicaid provider. That would include employees under the self-directed service delivery model, vendors, and DDA licensed and DDA certified providers. Providers, DDA licensed and certified providers, must complete the provider application and e-prep process and meet those standards, to include the renewal process, which must be completed 60 days prior to the expiration of their current license or certification. For employees and vendors, as outlined in Appendix C, they will need to meet the specific training and requirements that are noted. So for employees, in general, the requirements would be CPR and first aid, criminal background check. There may be some additional requirements based on the type of service, such as for employment services. And please note, under the self-directed model, participants as the employer record can also require additional training requirements for their employees and vendors.
Thank you. So are you saying that employees will be considered providers?
All individuals, employees, vendors, and DDA providers who are paid and receive Medicaid funds are considered to be a Medicaid provider.
Please explain how removing "unless otherwise approved by DDA" maintains person-centeredness.
Yep, that's a good question. So we want to be clear and transparent related to standards and criteria. And so unless otherwise authorized does not provide clarity in terms of when we would be authorizing services. So to be fair and equitable, we have noted in the waiver program, for example, when we would authorize dedicated supports, when individuals do not have a current behavior support plan or nursing care plan, that we would authorize that up to 6 months. So we want to, within our waiver program, be very clear in terms of the rules and the standards so that we're all aware of them.
Thanks, Rhonda. Regarding self-employment, I'm glad to see the requirements for self-employment, but I am wondering if those basics will include referrals to DOOR's RISE program for those genuinely interested in developing or supporting a small business.
Yeah, absolutely. We always and should continue to coordinate and work with the Division of Rehabilitation Services that offers a variety of supports and services. The waiver outlines that those services should be explored first and accessed if available. We do know that the Division of Rehabilitation Services has standards and caseload and funding opportunities too, so those should absolutely be considered through that program and others.
Thanks, Rhonda. Please clarify the statement. Clarified that virtual supports has an electronic method of service delivery and associated requirements shared during initial implementation.
Yep, exactly. Happy to share that. In a previous amendment, after the public health emergency, the DDA amended the waiver programs to include virtual supports as a service delivery model. And so we have the opportunity under community development services, personal supports, and a few others to be able to have providers create business models where they would be providing the services virtually versus direct in person. When we initially implemented this requirement, we had outlined the standards to include providers needing to have a program service plan outlining their business model and be approved for that in order to deliver those services. In addition, there are specific billing requirements when providers are using virtual supports in terms of specific details that they need to note in their billing on the provider portal side. So we are just ensuring that those standards and requirements that were initially established when we amended and added virtual supports to the waiver several years ago are outlined and included in this amendment for transparency.
Thanks, Rhonda. Can people with shift bill for assessments, or must one be a CSUN, RESNA, or other licensed or otherwise licensed?
Yeah, it's a good question. This question relates to assistive technology. And what we're doing is we're updating the provider qualifications to add shift enabling technology certification as a qualified provider for services. Assistive technology is very broad and it provides great opportunities for individuals to increase their independence through the use of technology. There are a variety of certifications depending on the type of needs of the individual that specialize in technology. So the waiver application, the waiver programs currently outline the different types of professional certifications that can support individuals depending on the type of device that's being used. So we are adding shift enabling technology as a certificate that of a qualified professional that can provide some of those services.
Thanks, Rhonda. What about homes with sleepover staff? Will the person's needs become someone available but does not require someone awake 100% of the time?
Yep, that's a good question. So we are currently provide funding to support staff overnight. And as a Medicaid program, we want to ensure the quality of service and that staff are awake and alert to support those needs. So the service will continue to be available and authorized as it currently is. The requirement would be for the staff to be awake and alert.
Thanks. Regarding employment, in general, your proposed modifications are excellent if sufficient employment staff that believe in an integrated individual chosen community employment and have sufficient training in developing truly individualized central plans. Sorry, I'm going to get to this question. Please clarify how you would determine if an individual who has not found and kept work in 2 years has received appropriate services before closing their case.
Yeah, that's a great question. So what we would look for in the person-centered plan first is to see whether the individual had an employment goal. We do have in our person-centered plan focus area exploration, and one of those areas that is required by legislation is employment. So if the individual does not have an employment goal, that would be one of them. So we would look to see if there was an employment goal, and what activities and actions were taken to support that individual towards achieving competitive integrated employment related to employment services if they have not received or been have not acquired a competitive integrative job in the last 2 years.
Thanks, Rhonda. And this will be the last question, although there are many other ones that have been submitted. Please clarify what the day-to-day administrator can be paid to do.
Yep, that's a great question. So what we've proposed in our waiver amendment is under the individual and family directed goods and services related to the day-to-day administrator. And so what we've noted is that the day-to-day administrative supports would help with household management and scheduling Medicaid medical appointments. So household management would be like coordinating and scheduling lawn service or snow removal. And then the scheduling of medical appointments. And so, Dr. Smalls, I know as we're ending our time for today, if you could go back to slide 90, and just we want to again share that we will again meet tomorrow if you're able to join us from 9 o'clock, the waiver application overview and input process. At 12, we'll review self-directed related topics. And then at 2:30, services and provider qualifications. The public comment period is from June 9th through July 8th. And if you can go to the next slide, Dr. Smalls, this includes the dedicated website for which you can access the proposed amendments that includes track change documents for you to review, and where you can submit your public comments for the document. Robert, I don't know if you wanted to close out, or Dr. Smalls, if there's anything else you wanted to add, I'll turn it over to you.
Yeah, thank you, Rhonda, and thank you to everyone who took time out of your day to join us to discuss and get an overview of what's in the new waiver amendment application for 2025. Again, just want to reiterate that we are currently in the public comment period. So I'd like to end with this slide, just for about a minute so folks can record this. We also attached the presentation to the webinar as well. Did see a comment related to removing PPT or PPTX from the file name, and we will be sure to do that in the future so that your desktop or laptop doesn't try to use PowerPoint to open a PDF. So thank you for that feedback. With that, let me turn it back over to you, Dr. Smalls. Thanks, everyone.
Thanks, everyone. As Robert just mentioned, the PowerPoint is available to you as a download in the handout section, and it will be uploaded to the DDA website as well as our DDA YouTube channel. Have a good rest of your day, everyone. See you tomorrow, hopefully. Bye-bye.